Assalamu alaikum. My name is Dr. Sajid and I'm a neurologist. I did my FCPS in neurology, followed by fellowship in clinical neurophysiology from Aga Khan University. Currently, I'm doing fellowship in movement disorders at the University of Virginia. And today we will discuss about neurodiagnostics. Before starting, I welcome all of the participants of the neurology certificate course. And I assure you this is a very nice course organized by Aga Khan and Dr. Mohammad Wase, and you will learn a lot from it. So today topic neurodiagnostic means the diagnostic tests that are usually used to diagnose the neurological conditions. So what are their utility? What is their limitations? We won't go in detail about each and every individual test, but we will give a general overview of the tests and their limitations. And these tests are something that you will read or hear about them again and again throughout this neurology certificate course. So the first question is why we perform tests. And nowadays there are very much scientific advancement like MRI, CT scans. So the goal of any encounter between a patient and a doctor is to reach at a diagnosis and treat the condition because the patient comes with some problem and you have to solve the problem. So to reach at a diagnosis, the crucial thing is the history. History is important. History is followed by physical examination. So again, physical examination has to be directed as per the history. After history and physical examination, then you go for the tests, which we call neurodiagnostics in our case, to reach at a diagnosis. Once you are at a diagnosis, then it's easy, comparatively easier to manage the condition because when suppose a patient comes to you with some tremor in his hands or her hands, tremor can be due to anything. He won't tell you, I'm having essential tremor, or I'm having Parkinson's disease, or I'm having physiologic tremor, I'm having dystonic tremor. So there are different types of tremors. The patient will come, I have tremor. Now, by taking history, by physical examination, and by tests if needed, you reach at a diagnosis. Yes, this is an essential tremor. How to treat it? Give propranolol, primidone, etc. Oh, this is a Parkinson's disease, Parkinson's tremor. Give him levodopa. Similarly, to reach at a diagnosis is the crucial point, and tests are only a part of reaching there. Most of the bulk is by history and physical examination. I'm just repeating it because you cannot go anywhere, you cannot order the test properly unless you have a good history and a good physical examination. When talking about different modalities, different tests and investigations that we have neuroradiological imaging. Now they look at the anatomical features or anatomical abnormalities. Then we have neurophysiological testing. Now neurophysiological testing tests the physiology or functioning of different parts of our nervous system. Then we have some other modalities like lumbar puncture, histopathological diagnoses for different biopsies, genetic testing, some serological blood testing that are used to reach at a diagnosis. Now, if we talk about the neuroradiology, so neuroradiology, as I said, sees the anatomy and structure of our nervous system. So it comprises of different types of tests like plain X-rays, CT scans, MRIs, angiographies, myelographies, magnetic resonance spectroscopy, positron emission tomographies, PET scans. Then there's a single photon emission computerized tomography, PET scans. So there are different types of imaging modalities available. Now, all of them are not similar. All of them are used in different scenarios All of them have different uh, advantages and disadvantages, and you should know which one to use. And then we have neurophysiological testing. As I said, neurophysiological testing tests the functional part. So there is an EEG, which stands for electroencephalogram. In EEG, we detect, we test the different waves in your brain, and there are different types of EEGs, like routine EEG, sleep deprived EEG, video EEG, ambulatory EEG. Then we have another test called EMG, that stands for electromyography, and NCS, which stands for nerve conduction studies. Again, there are different types like routine, EMG, NCS, RNS, which stands for repetitive nerve stimulation, autonomic studies, single fiber EMG. Then we have different evoked potentials like visual evoked potentials, auditory evoked potentials, somatosensory evoked potentials, motor evoked potentials. And finally, we have some sleep studies like polysomnography and multiple sleep latency tests. We will also discuss about them. Now, first talking about the plain X-rays. So plain X-rays can be of different regions. Plain X-ray can be of your skull. Plain X-ray can be of your spine or vertebra. So as we know, X-rays, that there is a X-ray waves grows over and they cannot cross the bone. So they produce a shadow, yellow shadow or white shadow, which we call translucent. And when it passes through the air, it gives us a black shadow. Since our brains are covered by bony cranium, so that's why it does not cross the cranium and we cannot visualize the brain, but we can visualize the cranium. Similarly, we cannot visualize the spinal cord, but we can visualize the vertebra. So if there is any abnormality in terms of bony abnormalities, usually like fractures, if there is any road traffic accident where there is a risk or suspicion of a spinal cord injury, X-rays can be done. Or if there are any injuries like any blunt objects, any bullets, you can always see them through X-rays. But since we have better imaging modalities, so X-rays are less used to diagnose the neurological conditions. They are usually diagnosed to see any bony masses, bony tumors, bony fractures, or as I said, any bullets or any artificial foreign bodies. Usually, the imaging modality that is used is either a CT scan or MRI. Now, CT scan is on our left and MRI is on our right. They look very much pretty similar to an untrained eye, but there is some difference. Now, CT scan, if you see, the outside is white. This is a bone which appears white. Now, if you know or if you have realized in X-rays, the bone appears white too. Why that so? Because CT scan uses the same X-rays. It's these X-rays grow at I would say higher frequencies. There are more X-rays which are deviated so that which are uh, come at a point to visualize the softer tissues. But the basic principle is same, that if rays do not cross any structure, the structure appears white. If the rays cross over all the structures, then they appear black, like black in air or in fluid in this case. If it some of them rays do cross, but some does not cross, then they appear gray. So that's why the bone appears white in CT scan, but in MRI they use magnetic resonance imaging. So the magnetic field is created and it's not the X-rays. It does not detect bony structures that well, so you cannot visualize the bone that well, but you can visualize the brain structures in more detailed as compared to CT scan. So just an example, the CT scan of the X-ray, this is commonly, I guess, seen by all of you. And what happens in X-ray of the chest, that when the rays pass through the chest, it cannot pass fully from the ribs. So that's why ribs appear a little bit more translucent, whitish. But it can pass through the air lungs. That's why the air lungs appear black. But if there is some blood or fluid here, as in the black circle, then the rays cannot pass through them. Since the rays cannot pass through them, it also appears white, translucent, or dense. The same things happen in the CT scan. So it cannot pass through the bony structure, so it appears white. If there is anything abnormal like blood, it will appear white. In CT scan, the brain tissue appears in various shades of gray, and the CSF appears black. While MRI has different phases like T1, T2, flare, and then again we have DWI, and there are a lot of different imaging sequences of MRI. But as MRI uses magnetic imaging and magnetic fields and not the X-rays, so all the MRI sequences do not detect or do not visualize the bony structures that well. So to visualize the soft tissue, MRI is recommended. To visualize the bony structures, CT scan is preferable. Now there are again some differences apart from using X-rays. That CT head takes less time. So the CT head is done in only few minutes. So this is the reason if someone is hemodynamically unstable, we cannot do MRI. MRI takes around 30 minutes to 1 hour. So we do CT scan. In cases of ischemic stroke, so in ischemic stroke, uh, there is a treatment available called TPA, tissue plasminogen activator. It is only given in patients who have an ischemic stroke, and so we have to exclude the hemorrhage. Now, CT scan detects blood very well, as it's written here. It's excellent to detect blood and bony structures. So if there is any hemorrhagic stroke in which there is a blood present, CT head will detect in seconds. If there is no blood, but there are clinical features suggestive of stroke, so we treat it as ischemic stroke. So TPA is given for ischemic stroke and not for hemorrhagic stroke. And it's important to differentiate them, because if we give TPA in a patient who has a hemorrhage, then it will increase the hemorrhage. It can even lead to significant damage, brain damage, and may lead to death. That's why it's important, essential to exclude the hemorrhage. How to exclude the hemorrhage? Do a CT scan. If there is no hemorrhage, it means it's an ischemic stroke. But question is, why to do CT head? Why not MRI? MRI detects ischemic stroke really well because CT head only takes few minutes to do. And when someone has a stroke, we have to save time. If we take 1 hour in doing MRI, there will be more brain damage as compared to CT head, which is done in few minutes. If there is no blood, there is only patient is diagnosed as having ischemic stroke, we can go for TPA and other treatments if needed. Another feature of CT scan head is that it's at low cost and it's easily available. You can find them in many centers. As I said, CT head is the modality of choice in acute stroke. So those strokes which present in less than 4.5 hours, so we do a CT scan. So if there is an hemorrhage, see, this is an hemorrhage. It appears as white, hyperdense. So when it appears as white, hyperdense, it means it's a hemorrhage. But in ischemic stroke, it can be normal or even it shows mild, if you say blackish shadow here, which is not present here. This shows an ischemic stroke. But this is the CT scan of the same patient done after 24 hours. So you can see this patient actually had this much big ischemic stroke, but it's not visible in early stage. So CT scan can be normal after 24 hours or may show milder changes than actual damage. So if there is blood, there is hemorrhagic stroke. If it is not blood, it is ischemic stroke. If patient's history and clinical features are suggestive of stroke. So this is one reason where CT head is usually performed. Since it detects blood very well, So other pathologies in which there is an blood is involved, like subarachnoid hemorrhage. So CT scan is recommended. You can easily see this blood in the arachnoid spaces. Or you see epidural hematoma. Sorry, subdural hematoma. So subdural is like this shape. Subdural hematoma, then it's a blood, white color. It is clearly visible here. Epidural, like a lens shaped. For the epidural hematoma, again, CT scan is performed. It can easily visualize the blood. Or if there is any bony abnormality, here you can visualize there is a fracture. So it's easily visualized on CT scan. So in these kind of scenarios, we prefer to do CT scan of the head. CT scan head can also be done and show when there is a suspicion of any infection. So they can, and usually these are done with contrast. So you can see different ring-enhanced lesions, followed by this around blackish hypodense shadows showing edema. Again, it can be CT scan can be done to visualize the ventricles. Here you can see the ventricles are dilated. Ventriculomegaly or hydrocephalus can be due to many reasons. Here, a shunt has been placed, so you can even visualize the shunt which is present in the ventricles. So CT scan is also used in these kind of scenarios. But there are certain CT scan limitations. The first limitation is that CT scan does not visualize posterior fossa that well. So posterior fossa includes structures like cerebellum or brainstem, like midbrain, pons, medulla oblongata. So these kind of structures are not very well visualized by CT scan. So if you are having suspected any pathology in these structures, then MRI is usually preferred. Two, it has a low resolution, so you cannot exactly see the exact structures. Like you cannot exactly see the basal ganglia, the substantia nigra, or the nerves, which can you can see through MRI, and you can even miss small lesions. So if you are looking for any deep brain pathologies, and if you need smaller lesions, then MRI is preferred as compared to CT scan. Now, about the MRI. Now, MRI, as we discussed, takes more time, around 45 to 60 minutes to be done. It has a very high resolution, so it detects even small lesions, and it's excellent to detect soft tissues, any pathologies in brain, in the spinal cord. Now, MRI brain, again, there is a misconception too. Some people say CT scan detects hemorrhage well. It does not mean that MRI does not detect hemorrhage or ischemic stroke. MRI brain, it's excellent for all types of stroke, say ischemic or hemorrhage. But why we prefer CT scan? Because it's done quickly and we have to decide whether to give TPA or not. So if somebody is present in within 4.5 hours, go for CT scan. See if there is any hemorrhage or not, and then treat accordingly. But suppose if some patient is coming after 4 and 5 hours, after 4.5 hours, like coming after 6 hours or after 12 hours, we do not have to give TPA. Then we can directly go for an MRI brain to exactly localize where which type of stroke it is and how big or small it is. Another thing, the MRI brain is excellent for demyelinating disorders. So there are certain demyelinating disorders like multiple sclerosis, MS, ADEM, ADEM, acute disseminated encephalomyelitis. So there are these are the demand conditions in which it is preferable to MRI because CT scan won't show any abnormality. So these are different sequences of MRIs of different patients. Here you can see this is a DWI imaging. How why it is DWI, I'm not going in detail, but I'm just showing you this white shows the area of ischemic stroke here. On the right side, just near to the ventricles, at the side of the ventricle. This is the basal ganglia area, or the thalamus. It's also here. Here you can see in images there are small renal lesions diffusely throughout, showing some kind of infection, probably some diffuse toxoplasmosis maybe. Here again, a heterogeneous contrast uptake seems like a tumor. Here, what we call dorsal fingers, these are seen in a sagittal section, and you can see them just around the ventricles, like the fingers. And these are very much suggestive of multiple sclerosis. Now, MRI spine, now these are the vertebrae. Now, in between the vertebrae, there is this intervertebral disc, and these are the spinal cord. Now, spinal cord usually tapers around here, L1, L2, then their nerves are coming. Here you can see there is something that compressing between L4 and L5. So if there are any spinal problems, they are also very much detected by the MRI. Now, this is a summary of what we discussed, and there is a very good presentation by Professor Mohammad Wasef, and he will discuss more about CT scan, MRI, and the differences between them. So this is just an MRI machine, and many people become very much claustrophobic when they go inside. So nowadays there are also some open machines where it's it's cut here, and there's only the upper portion and the lower portion. So this is how a standard MRI machine looks like. Now, apart from the MRI and CT scan, there are other studies like angiographies. Now, angio means vessels, graphy means to see, to visualize. Now, these studies are done to visualize the blood vessels. There are different modes to do it. We can do CTA, CT angiography. We do MRA, magnetic resonance angiography. Now, these CTA and MRI can be, CTA is done with contrast, MRA can be done with contrast or without contrast. And then there's a DSA, it's called digital subtraction angiography. Now, DSA is like the angiography which is performed for coronary diseases like coronary angiography. You pass a catheter either in the femoral artery or in the some radial, and then go all the way to the brain and directly visualize different vessels. You can even do different uh, procedures. Then we also visualize the carotid arteries here. It can be done with the help of some ultrasound, Doppler ultrasound studies. And then there are transcranial Doppler studies can also be done for different conditions like sickle cell disease or brain death. Now, why to visualize vessels? Uh, to for different conditions, like there are different aneurysms that may cause subarachnoid hemorrhages, to clip them, to treat them, and sometimes to see any stenosis so that appropriate treatment is given, like carotid artery stenosis. To see the vessels, even veins, we see veins like MRV, magnetic resonance venogram, or CTV, CT scan venogram. So these are performed to see venous sinuses in your brain because there are certain conditions that also affect the venous sinuses, such as CVST, cerebrovenous sinus thrombosis. So in these conditions, you order these tests. Now, this is a fairly advanced test called MRS, magnetic resonance spectrogram. It's not available everywhere. It's present in Aga Khan University. So what happens? So if there is any lesion, see, this is just a one cut in which you can see a lesion here, in another, this lesion here. So if there is any lesion, the CT scan or MRI give you like possible differentials. Like it can be tumor, it can be infection, abscess. Sometimes these are very much clear with the help of history and examination along with MRI or CT scan findings. But sometimes the lesions are not diagnostic and we are not sure what it is and we need a biopsy. So usually you do a neurosurgeon usually cuts the dead part or the lesion of the brain, maybe remove it completely or only just take a piece of the tissue and examine it. But sometimes it is not possible to do the biopsy because the lesion is present in such a critical area like in brainstem. So brainstem, as you already know, there's medulla oblongata, there's bones, there's midbrain, there are centers that control our heartbeat, that control our respiration, that control our consciousness. So you cannot just go there and take a biopsy. Patient can die even at the table. So sometimes it's difficult to diagnose what to do because, as you know, for further management, you need a confirmed diagnosis. There's different management for meningioma. There's different management for glioblastoma. There's different management for CNS lymphoma. So sometimes in these cases, MRS can be used. So MRS, even though it's an imaging, it does measures different parameters like what is the choline concentration in it, what is the lactate concentration in it, what is the phospholipid concentration in it. So by measuring these concentrations, they give an idea what this lesion might be. So this is an MRS. Then we have PET and SPECT. It shows various colors depending on the activity of the part of the brain. And sometimes we use a radioactive substance, and this detects how much this radioactive substance is taken up by that part of the brain. So these are also used in some cases. Now we will talk about clinical neurophysiology procedures. As we discussed in the starting, the neurophysiology procedures, they do not see the anatomy, they see the physiology, the functional part of different parts of nervous system. And we have different tests. We first talk about the nerve conduction studies and EMG. So as the name indicates, nerve conduction studies. So these studies are done to assess the function of different peripheral nerves. So there are some neuron cells within the CNS, within the brain, and there are other nerves growing in your limbs, in your arms, legs, like radial nerve, ulnar nerve, median nerve, sciatic nerve. So you assess the integrity of these peripheral nerves. So it helps in the diagnosis of various peripheral nerve disorders. Now, this is important. So it is useful in the diagnosis of peripheral, not central. So if someone has radial neuropathy, NCS will be helpful. If somebody has median neuropathy, carpal tunnel syndrome, NCS will be helpful. If someone has a radiculopathy, cervical radiculopathy, lumbosacral radiculopathy, EMG, NCS will be helpful. But if someone has stroke, so stroke is a central problem. If somebody has multiple sclerosis, it's a central problem. If somebody has ADAM, if somebody has epilepsy, then NCS won't be helpful. EMG won't be helpful because it is only for the peripheral nerve disorders, not the central disorders. Not only it helps in diagnosis, but it also localizes that where is the problem, whether the problem is in nerve root, like radial nerve, the problem is in plexus, like brachial plexus, or the peripheral nerve. So this is a cross section from the spinal cord all the way to the muscle, and this is the roots. This is the dorsal root. This is the ventral root. Both combine to form spinal nerve, and the spinal nerve goes all the way to the muscle, and this is the neuromuscular junction. So any problem starting from motor neuron all the way to the muscle, this can be diagnosed or localized with the help of EMG and CS. So if there is a motor neuron problem like ALS, amyotrophic lateral sclerosis, EMG and CS can diagnose it. If there is a peripheral nerve problem, sciatic neuropathy, radical neuropathy, it can help. If there's a motor nerve problem only, sensory nerve problem only, it can detect. If there is a neuromuscular junction disorder like myasthenia gravis, Lambert-Eaton syndrome, EMG and CS can help in diagnosis. If there's any problem in the muscles, like different myopathies, muscle weaknesses, EMG and CS can help. But if there's any problem above this motor neuron, like in the spinal cord here, or in the brain, then EMG and CS will not be helpful. EMG and CS only tests this part of the brain, nothing else. So what are the utility of EMG and CS? So EMG and CS detects if there's any problem or not in the peripheral nervous system. If there is a problem, it detects whether problem is sensory, whether it's a motor or it's a missed one. It also tells you whether only one nerve is affected. It's a polyneuropathy. Multiple different nerves are affected. And also detects how much severe it is. Is it a mild neuropathy like CTS, moderate CTS, severe CTS, to give not only to diagnose the condition, but also to give the appropriate treatment. And then in some cases, the NCS also helps to detect the pathology, like whether if there is a neuropathy is present, it's a demyelinated neuropathy or axonal neuropathy. Now I'm saying these because each nerve has a myelin sheath. So there are some disorders like GBS, Guillain-Barré syndrome, in which the myelin sheath is affected. So it will, EMG NCS will give you your answer, will help in the diagnosis that it's a demyelinated condition. So GBS is treated with plasmapheresis or IVIG. If it's axonal can be due to many reasons. The commonest cause is diabetic neuropathy. So you do not have to give plasmapheresis or IVIG in these cases. So in some times, this EMG NCS helps also in differentiating different disorders. Again, as I said, it tells us the severity, so it assesses the prognosis. For example, in traumatic neuropathies, there is some injury. So we have to see whether the injury is severe or mild. If it's mild, there's good prognosis. If it's severe or if it's completely cut, the prognosis is poor. And again, for follow-up of the diseases. So if someone has a neuropathy now, we can again do it after 1 year and compare whether the neuropathy has worsened or is it getting better or is it the same. So these are the different uses of NCS. Now we will talk about the electromyography. Now, name indicates electro means the electrical activity, myo means muscles, and graphy means the graph to view. So we view the electrical activity within the muscles. So this EMG is usually performed after NCS and it is only interpreted in combination with NCS. So you cannot do an EMG separately. It has to be nerve conduction study followed by EMG. So it assesses the integrity of the muscles and differentiate whether the problem is nerve or muscle problem. So it's a neuropathy or a myopathy. Sometimes it also helps in diagnosing whether the weakness is true or not. So sometimes some patients have muscle weakness, but the weakness is not due to being muscle being weak, but because they have severe pain or they cannot want to move. Now, EMG NCS has certain limitations. So it is performed by inserting a needle in a muscle. So that's why patient cooperation is very much necessary. And patient should be conscious because suppose I am checking a bicep muscle. So what I have to do, I have to insert the EMG needle in bicep. And then I have to contract this muscle. Now we know what biceps do. Bicep flexes the elbow. So we have to ask the patient to please flex the elbow. So once patient will flex the elbow, then we will see the electrical activity. So that's why the two things are necessary. Number one, we have to insert the needle in the right place. Second, patient has to be cooperative and should follow our commands. So if patient is unconscious and he cannot follow our commands, he cannot flex his arm or cannot move the muscle, we cannot view the muscle activity. So EMG will have no value if someone is unconscious or is not following your commands. So this is how a nerve conduction study is performed. There's usually, you have this stimulator here and you place these electrodes where the nerve crosses. So the median nerve crosses here and it supplies these muscles. So we have electrodes here and we stimulate and see how fast the current moves from here to here. And this is how we find the graphs. I'm not going in detail to interpret it, but this is how we see the nerve conduction study results. Now this is EMG. Now, as I told you, it's performed by EMG needle. So the needle has to be inserted into a muscle and these are different electrodes. And this is how a muscle activity is seen. Now, routinely, nerve conduction in EMG has these two components, the repeat nerve stimulation and EMG. But sometimes, like, we have to order further tests to diagnose a condition, such as repetitive neurostimulation. Now, what happens in repeated neurostimulation? Uh, in nerve control studies, suppose I have to check the median nerve, I stimulate at the median nerve and I record at the median muscle. Now, this is how it is done routinely. But in repetitive nerve stimulation, I have to repetitively stimulate the nerve. It has to be done at at least 3 times per second. So it's a 3 hertz. It can go all the way up to 30 hertz, and it's quite painful. So repeatedly, a nerve is stimulated and response is recorded, and we have to see is the response stable or the response decreases or increases. By this, seeing the how the response varies, is it decreasing, is it increasing, it helps us in the diagnosis of different disorders, especially the neuromuscular junction disorders that include myasthenia or Lambert-Eaton syndrome. So RNS is a special technique. No laboratory will perform RNS by their own. You have to especially mention that please do EMG and CS with RNS if you are suspecting a neuromuscular junction disorder. So RNS detects neuromuscular junction and helps in the diagnosis of neuromuscular junction disorders. And it also helps to differentiate whether the disorder is presynaptic, like Lambert-Eaton syndrome, it's a presynaptic, or postsynaptic, like myasthenia gravis, it's a postsynaptic neuromuscular junction disorder. Again, RNS has certain limitations. RNS can be positive in 10% of the cases if it's in like an ALS, amyotrophic lateral sclerosis, or polymyositis. It can be false negative too. Like in 15% of the patients, RNS can be normal even though patient has myasthenia. So that's why the limitations have to be understood and have to be interpreted in terms of clinical examination and clinical findings and clinical suspicion. So this is how RNS looks like. So you repeat frequently, and these are the repeat nodes. The first stimulation, second stimulation, third stimulation, fourth, fifth, and you will then see how the response is, whether they are decreasing, increasing, is the same, and you evaluate it accordingly. Then there is a single fiber EMG. So normally in EMG, whenever a muscle contracts, we see a lot of muscle fibers all activating at the same time. In the single fiber EMG, we only visualize the one fiber and we see how this fiber changes when muscle is contracted. So it is only performed for neuromuscular junction disorders like myasthenia. So RNS is also done for it, but RNS is a nerve conduction, and single fiber EMG is also done to diagnose or to help in the diagnosis of neuromuscular junction disorders. Then there are certain autonomic testing. So certain autonomic neuropathies. So what are the autonomic features? First, I talk about it. So our autonomic features are like erectile dysfunction. It goes with parasympathetic stimulation. So whenever there's a abnormality in parasympathetic or sympathetic stimulation, then we say autonomic problems. So patient can have problems with heart rate increasing too much or heart rate not increasing, even though you exercise. There may be too much sweating, even though you are sitting in a air conditioned room or you are sitting in a winter season with temperatures of 0 degrees centigrade and still you are sweating, or lack of sweating. So it's hot outside, it's 50 degrees centigrade, you are running and still there is no sweating. There will be uh, there are maybe some GI problems like early satiety, constipations, diarrhea. There can be some dizziness, syncopes. So there are different autonomical features. So when you are suspecting an autonomic neuropathy, then different autonomical testings are done, like QSART, quantitative pseudomotor axon reflex test. Pseudomotor means they detect the sweat. So how much sweat is there? Then there's a sympathetic axon reflex test. There are RR interval, respiratory rate intervals. Then inspiratory expiratory ratios, tilt table testing. So there are different type of autonomic testing that can be performed to detect the autonomic neuropathy. Again, these tests are not done routinely in every patient. Now, there are some tests are also done in neurophysiology, but you have to specifically mention that you want to look for autonomic neuropathy. Now, EEG. Now, electroencephalopathy, what it does, it detects the electrical activity of the brain. How it detects? You have to place certain electrodes all over your system, all over your scalp, sorry. Now, it's not like you have to place anywhere. There's a system we call 10-20 system. So there are specific regions where you have to place each electrode and they are numbered. So they are numbered either on the odd, like 1, 3, 5, 7, 9, or they are numbered in even 2, 4, 6, 8. So if it's an odd number, like 1, 3, 5, it means it's left side. If it's even number, 2, 4, 6, 8, it's the right side. Now then these electrodes are connected with each other to record the differences in between the electrical activities or the difference between voltages. So this is the system by which they are used. As I said, they are numbered. So one odd number, this is the left side, 2, 4, 8, this is the right side. Further, there are alphabet too, like F stands for frontal, T temporal, P parietal, O occipital. Z usually stands for midline, so frontal midline, central midline, PZ, parietal midline. So that's how they are named, and they are connected with each other to know the difference between this voltage and this voltage, and the waves forms are formed accordingly. So I'm not going again, not detail why these waveforms are formed. You just know that EEG is done to record the electrical activity and why it's done. It's usually done for the evaluation of epilepsy. So it helps in the diagnosis of different epilepsy syndromes. It also helps us in locating the focus that whether epilepsy is generalized, which is focal, it is coming from frontal area, parietal area, from right side, from left side. So why it is important? One, there is a different treatment options for generalized epilepsy and different treatment options for focal onset or partial epilepsy. Two, in generalized epilepsy, usually there is no organic structural lesion. So usually it's not mandatory to have an MRI, but if there's a focal lesion, a partial onset, so it means there is some problem, some irritation at a particular region, like right frontal, left frontal, right temporal. So you have to do a brain imaging, especially an MRI brain, to look if there is any structural lesion, any tumor, any infection, any blood that is causing this epilepsy waves. So EEG is also done to diagnose non-convulsive status epilepticus. So we all know status epilepticus when a patient is continuously seizing for more than 5 minutes, or if someone is having two episodes and is not becoming awake in between the episodes, we call convulsive status epilepticus. By convulsive means we see patient is having seizures clinically. But sometimes patient has non-convulsive status epilepticus. So patient is seizing, patient is having seizures, brain is discharging from everywhere, but still we cannot see anything visually. So patient is not contracted, but patient is just feels like he is in coma. So how to diagnose it? We cannot diagnose it clinically because clinically we cannot see any difference apart from patient is not responding. So diagnose it with an EEG, and EEG will show there are epileptic discharges coming from everywhere. So if you are suspecting the patient is having non-convulsive status epilepticus, then EEG should be ordered. So when to suspect someone is having non-convulsive status epilepticus? Uh, Especially it can be suspected when there is some brain problem, like some is having CNS infection and despite treatment is not awakening up. Somebody has a stroke, but we don't suspect this to be unconscious, but he's unconscious. So we say maybe there are some discharges coming and patient is in non-convulsive status epilepticus. So we order an EEG. The another utility of EEG is to differentiate between conversion disorder and true seizure when patient is symptomatic. So we have to see sometimes patient is seizing and we are not sure whether it's a real seizure or a conversion disorder or what we call cytogenesis seizure. So we have to do an EEG at the same time when patient is seasoned. If patient is not seasoned, EEG can be normal. Remember it. I'm repeating again. If patient is not having any active seizure, even in patient with epilepsy, EEG can be normal. So if a patient has normal EEG, it does not mean he does not have epilepsy. But if a patient is seasoned, it's having a seizure, and you are doing an EEG, and EEG is normal at that time, it means this is a conversion disorder. It's not a epilepsy. So that's why we do video recording and see a patient, or we do the ambulatory EEG, in which EEG is placed for 24 hours, 48 hours. And if patient seizes in during that event, we see what are the EEG changes. If there are EEG is normal, we say this is not epilepsy, this is a conversion disorder. If patient is having discharges, we say yes, yes, this is an epilepsy, and we have to treat it accordingly. Apart from epilepsy, EEG is also used for different encephalopathies, for CJD, Creutzfeldt-Jakob disorder, for SSPE in some of the patients who had the measles in pediatric population, sometimes for assessment of brain death or some degenerative conditions, chronic infections. But the main majority of the reasons to do EEG is epilepsy. So, as I said, one of the limitations of EEG is that a normal EEG does not rule out an underlying seizure disorder. So you have to do multiple EEGs. Maybe you find some. But if somebody is seasoned and you are having an EEG and at that time it's normal, then you can safely say, since patient was having a seizure and EEG does not show any activity, it's not an epilepsy. But in a normal person who is not having any seizure activity, even in epileptic patients, it can be normal. So a normal EEG does not rule out an underlying seizure disorder. So routine EEG comprises of at least 15 minutes, and it is preferable to obtain sleep as well as awake recording. So patient should be awake and EEG should be recorded. And some part patient should be sleepy. So since it's only done for 15 minutes or 20 minutes, so we do not always get the sleep part, but we get the awake recording. And we usually also do some maneuvers when you are doing the EEG, like hyperventilation. We ask patient to hyperventilate for few minutes, like hyperventilation, and then for few 30 seconds to 1 minute or 2 minutes, we give intermittent photic stimulations. There are bright lights, they come and go, come and go. Why these are done? There are certain epilepsies, they are triggered by doing these maneuvers, like absence seizures. It is common in children. The absence seizures is triggered by hyperventilation. So sometimes when they hyperventilate and the epileptic discharges come. Similarly, there is another epilepsy syndrome called JME, juvenile myoclonic epilepsy. They are triggered by photic stimulation. EEG can be normal, but when you give these photic stimulation, you can see the typical epileptic discharges of JME. So this is how a normal EEG recording looks like. So these are the discharges, generalized discharges. You see, I'm saying generalized because they are happening in all the electrodes. Then there are various sleep studies like polysomnography, multiple sleep latency test. They are performed for different reasons. Then we have evoked potential. So what happened in evoked potentials basically? So if we talk about evoked potential means we give a stimulus and then we see the response. So visual evoked potential mean we give a visual response and see visual stimulus and see the response. So what happens in visual evoked potential? This is a person, there is electrodes attached. Now there is a checkerboard, like a chess-like board, and there will be a lights changing. So this is a black box, this is a white box, so they alternate. So after some time, this black becomes white, this white becomes black, so they alternate. So this is a stimulation that is given to the patient, and because of this stimulation, there is a waveform that is formed in the occipital region, which is involved for the vision. And a wave is formed like this. And we evaluate this form, whether it's normal or abnormal. It is seen in many, it is used for many different conditions, the common being multiple sclerosis or optic neuropathy. As I said, visual VEP is usually done for optic neuritis or MS. And then there's a brainstem arterial potential. Again, you give a auditory stimulus that passes from ear up till to the brain, and we see different nerves. So this is a normal BEP wave, and it is usually done in children to see their hearing, if their hearing is fine or not, especially who have a speech delay. So we are not sure why the speech delay is. Is it speech delay because patient is not hearing, child is not hearing, or due to other reasons? So that's why usually this brainstem evoked potential is performed, and helpful in localizing the hearing deficit. Okay. Then the lumbar puncture. I know many of you know about the lumbar puncture. So what happens in lumbar puncture? So a needle is inserted into the lumbar space in L3, L4, or L4, L5 usually, and sometimes in L2, L3. As the spinal cord usually ends at the lower margin of L1 or upper margin of L2. So when you go below the L2, there is no risk of damage in the spinal cord. So you insert the needle and you drain fluid. Usually it's done for diagnostic purposes, but sometimes it's also used for therapeutic purposes as a treatment, either by draining the fluid or inserting some intrathecal medication. It can be performed in lying position or in sitting position. The only difference is that you cannot measure the opening pressure in sitting position. If you want to measure the opening pressure, the patient has to be in the lying position. If patient is sitting, there will be gravitational forces occurring on the CSF. So it will show a high CSF pressure, higher than normal. So that's why if you want to measure the opening pressure, the patient has to be in the lying position. So why the opening pressure is checked? Because in certain conditions like normal pressure hydrocephalus, the opening pressure has to be normal. In pseudotumor cerebri, which is the older name for benign intracranial hypertension, the opening pressure is high. The opening pressure is also high in various CNS infections. So there is a utility of checking the opening pressure. So what are the indications of lumbar puncture? The lumbar puncture is indicated if you are suspecting a CNS infection, you are suspecting any metastasis to the meninges, some inflammatory disorders like multiple sclerosis. As I said, for pressure measurement and for therapeutic. Sometimes you drain fluid, which is used as a therapeutic for normal pressure hydrocephalus, and also you can give certain medications. So what are the contraindications? When we cannot perform lumbar puncture, when there is a risk of high intracranial pressure. So high intracranial pressure can be due to any tumor. So if you're suspecting any tumor, it's better not to do a lumbar puncture. If a patient has focal deficits, so somebody has weakness on one side, any sensory problems on one side. So we suspect since its problem is on one side, there is a high possibility there is something present in the brain, some structural lesion. So we cannot do lumbar puncture. We first have to do a brain image. So when to image before lumbar puncture? So does every patient who has to undergo a lumbar puncture, should they do a brain imaging? The answer is no. We only have to order the brain imaging before lumbar puncture if patient is papilloedema. So you have to see the optic disc using fundoscope. And if there's a papilloedema, so papilloedema indicates there's a high intracranial pressure. So you have to then perform a brain image. So if there's a focal deficit, you think there may be a structural lesion. That's why you have to do an image. If there are recurrent seizures or mental status changes, then again you think like there may be something going on in the brain. So it's better to image and rule out any intracranial pressure or structural lesion before doing a lumbar puncture. So in these conditions, an imaging has to be performed. If these conditions are not present, patient is awake, there is no papilloedema, there is no focal deficit, you can do a lumbar puncture without ordering a brain imaging. So what are the complications of lumbar puncture? The most common is the local pain. So where you inserted the needle, there is local pain. And second is headache. Now this headache is a typical headache. We call them low pressure headache. So what happens in this headache when patient is lying supine, the headache gets better. When patient sits or stands, the headache gets worse because there's more gravitational pull and more loosening of CSF. So the treatment is simple. You have to give increased caffeine. So increased caffeine is present in coffee, in tea. Increased caffeine is present in different sodas like Coke. Increased caffeine is present in different medication like Panadol Extra. So in Extra, you have caffeine along with uh, paracetamol or the acetaminophen. So that's why it's called Panadol Extra because it has increased caffeine. So the simple Panadol will won't work, and you have to give Panadol Extra in these patients. And this is usually limited. Most patients get better after a day or two. Rarely, there may be some infection or nerve root damage after doing a lumbar puncture, but these are very rare. Now, histopathology. Now, you can do some histopathology testing too. So, if you are suspecting any pathology, you can do a muscle biopsy, even a nerve biopsy. As I said, for different lesions, brain biopsy is performed, meningeal biopsy. So, these can be visualized under a microscope using different stains. But these are not routinely performed. Why? One, it's painful. Two, we do not have enough expertise. There are not many trained personnel, and we do not have enough stand-in available. Or if they are available, they are super expensive. So that's why they are not routinely performed. So these are, and they have certain limitations too. But these are the tests that are available, that are present, but not performed as much as they should. Then we have certain genetic testing available for different epilepsies. The genetic epilepsies, different muscle disorders, the muscular dystrophies, hereditary neuropathies, anterior cell disorders. Genetic testing can be done. The specimen can be taken from blood or from buccal mucosa. Usually, we send these tests and usually outside Pakistan to different centers where they perform the genetic testing. Then there are some blood testing that are usually performed to reach at a etiology of the diagnosis. Suppose someone has a myopathy, muscle disease. So we look for CPK, aldolase, lactate, metabolic screen to look for these are elevated CPK, aldolase in muscle disease. But to find the cause of the muscle disease, so for example, muscle disease can be due to thyroid disorders. So thyroid screening is performed. Neuropathy can be due to diabetes mellitus. So diabetes screening is done. We check for fasting blood sugar, hemoglobin A1C. Myopathy can be due to vitamin D deficiency, so vitamin D is checked. Neuropathy can be due to vitamin B12 deficiency, so vitamin B12 is checked. So different serological tests are done to reach at a specific etiology of the condition. Then systemic diseases like vascular risk factors, that cause stroke, or they are risk factors to cause a stroke, like elevated blood sugars, lipids. You see echo or Holter monitoring to look for atrial fibrillation. There are certain conditions hypercoagul- that cause blood to be hypercoagulable, like uh, some clotting factors problems, deficiency of protein C, deficiency of protein S, prothrombin factor problems. So these have to be checked because these cause patients to form blood clots. And once there are increased risk of forming blood clots, there's increased risk of having ischemic stroke. If we are suspecting some inflammatory problem, there are certain Connective tissue disorders, they also cause neurological conditions. They cause myopathy, myositis, or neuropathies even. So we can go for checking ANA, anti-double-strand DNA, NCA, ENA, S levels for sarcoidosis, calcium. If we are suspecting these disorders, we can do autoimmune encephalitis panel, proper antibodies, even paraneoplastic panels, hormones, vitamins, iron studies to reach at a different diagnosis. So these have to be ordered depending on individual patient. So what we think is the risk factor depending on the history examination. That's why, if you remember my initial slide, I said history and physical examination are important. Then we can say, suppose someone has a myopathy but also has features of SLE, you have butterfly rash. History is suggestive of SLE, like diffuse joint pains, oral ulcers, multiple fetal losses. Then you think about, oh, the myopathy may be due to SLE. So let's order ANA, anti-double-strand DNA. But if you don't know the history, you don't know the examination, you will never order these investigations and you may never reach a diagnosis. So these are a brief umbrella overview of all the neurodiagnostic testings. So if there are any questions, I will be happy to answer. There are my two emails are also written here. One is the Gmail, others here my work email. So if you have any questions, you can always email me. I hope you learned something and all the best for future presentations. Thank you very much.